What we're going to do here is talk a little bit about just general aspects of cultural and linguistic competence, and as Doug was mentioning, they really permeate all parts of healthcare, not only from patient satisfaction standpoint and quality and safety, but we know it has a lot to do with impact on how we use our resources, especially end-of-life issues, et cetera, are all culturally and linguistically related. We're going to talk a little bit about healthcare disparities, and also we're going to talk about the CLAS standards, because St. Luke's Hospital as a system a couple of years ago decided to adopt the CLAS standards as part of their system-wide response. In terms of disclosures, since this is being videotaped, I have to disclose that unfortunately I went to drug companies and pharmaceutical reps and I couldn't get anybody to sponsor this talk, so there's no financial disclosures I have to make. In terms of disclaimers, I would tell you that actually there are about 56, 57 of us who took a cultural competency fellowship that was actually sponsored by the American Hospital Association. It was a year-long training program, and I would just tell you that these discussions are complex, they're continually changing, a lot of sensitivities come up when you discuss cultural and linguistic issues, and we must avoid the risk of stereotyping, and I'll talk about that a little later on. I want to put this picture in because this is what the St. Luke's internal medicine class used to look like here. Joe Brewer's not here right now, but he's there, Chris Perryman. We've changed a lot, and there were only like 10% female back in the days that we were internal medicine residents here. And the hospital typically took one African American. I looked at the 2 or 3 years before me and the 2 or 3 years after me, and that was sort of the standard back in those days. So when I started taking this fellowship, it was interesting. There was just a whole lot of cultural terminology that came up. Cultural congruence, cultural relativism, ethnopharmacology. As you know now, we can actually look at tailoring some drugs based on race. Pharmacoanthropology, all of these terms are developing because of this specialty. And so it brings up the question, what is culture? And there are a lot of different definitions of culture that are out there. Krauss is one who's published a lot on this subject, and it talks about language, thoughts, communication, actions, customs, belief, values, etc. Are part of culture. So when we look at those terms, race and ethnicity, one of the things that I think is important for us to realize is that race is basically a social construct. Historically, that's how it developed. And it was based, of course, on physical markers. And we know now through the Genome Project that 99.9% of us are all the same. And in fact, there are actually more intra-racial differences than there are interracial differences. You know, we think of maybe African Americans being tall, but then you have to think of the pygmies. And you think of, let's say, Asians as being short-stature people, let's say Chinese, and you have to think of Yao Ming, who played for the Houston Astros, or the sumo wrestlers. So, I mean, there are a lot of variations even within certain races. And then, of course, ethnicity. And a lot of crossover between race and ethnicity, but religion, natural origin, and if you actually look at the OMB, Office of Management and Budget, who basically comprises all the statistics we look at nationally, you wouldn't be surprised to know that the American, English, and French and German roll up under a sub-ethnic category of European Americans or whites. But you might be surprised to know that Egyptians, Iranians, Iraqis, Afghanistan, all of these also roll up under the classification category as a white race. Also sort of interesting is that if you look at Asians, you're not surprised to see that Chinese and Japanese are considered Asians, but Indians are considered Asians. People from Pakistan are considered Asians. So again, when you start looking at some of the details of how we classify people from our governmental standpoint, and these categories have actually changed over the years. Even the term Hispanic and Latino, that's changed. It kind of depends on, you know, more if you're on the East Coast, the term Hispanic is used, as opposed to on the West Coast, it's more Latino. But this actually is changing as people tend to migrate as well. So brings up the question, what's my culture? If I were to ask you, Greg, what would you say is my culture?
I kind of think it's counterproductive to try to put people into culture.
Well, okay, so multicultural. What sort of things would you include in my culture?
medicine culture.
Medicine culture, okay, excellent, that's one.
You're a Midwesterner.
Midwesterner, great.
Mid culture.
Pardon me?
Mid culture.
Ah, okay. Anybody else?
Rockhurst grad.
Ah, that's right, you learned about that. So you might assume I'm Catholic and so forth. So the important thing about this as just an entree is that it's been estimated that each individual probably represents, to Greg's comment, about 80 different cultures, okay? So, I mean, there are things that we look at, typically race and age and gender. I mean, all these things are sort of generational, or some of these things are generational. Obviously, a 60 or 75-year-old lady from the South, you might approach differently than a 25-year-old woman from Hollywood. But there are things that we sort of know, part of their personality, then there are things that we don't know, their parental status, personal habits, their religion, their spirituality, and then there are what we call functional classifications, what kind of jobs they have, where they are at that job, any kind of affiliations that they have. And all these things play into how we culturally approach someone. And in fact, even time and culture in country, we know that just for instance, breast cancer in women, if you look at Asian women that are born in Asia versus their first generation versus their children that are actually born here, their rate of breast cancer actually doubles. So we know that there's an environmental factor that plays a role there. Space issues in terms of culture. It's typically recommended that if you don't know someone that you don't go any more than 2 feet into their space without asking permission. Language communication issues, voice, quality, pronunciation, intonation. You know, you can have somebody that says, you know, you're a hell of a doctor. And you kind of wonder, are you saying, you know, you're a hell of a doctor, or you're a hell of a doctor? So all of these things play a role, especially how people interpret what we say to them, and they're important. Time constraints, all of these things affect how patients perceive us and how our care. And again, the idea is that most of these things we see are, that we are aware of, are things that we can see on the surface, but there's much more underneath. So we start with sort of ethnocentricity, unaware that others have a different worldview. Everybody thinks like me because, you know, I grew up in America and all Americans think the same way, which obviously is wrong. So that's where people typically start on this journey, and then we develop ethnosensitivity. We're aware that other people don't necessarily have our same worldview or experience, and then that helps us have ethno-relativity, where we respect other people's values and their cultures. So this process of becoming culturally competent, or I think probably a more appropriate term is delivering culturally appropriate care, you first have to be culturally aware that you're different. For instance, let's say if you woke up in France, you first would realize that everybody around you is not speaking English. Then you have to have a desire to assimilate into that culture, to understand some of those things. You develop those cultural skills, you develop the knowledge, and you have cultural encounters, and all of that helps you to become more culturally competent, or if you're a clinician in providing care to patients, provide more culturally appropriate care. So what's the most important part of this cultural competency journey? What would you think it would be, given what I've shared with you so far? Well, actually, the first part is managing your own prejudices. You know, if you have a patient that comes into your office looking like this, you'll have a different expectation versus a patient that comes into your office looking like this. And how are you going to manage those prejudices? I will tell you that when I first started in the emergency room, I wore a tie and I wore a suit and a jacket. Why do you think I did that? I wanted to make a good first impression. So the point is that we have to realize that all of our patients that see us already have a first impression. I wanted to make a good second impression. When I walk in a room, they already knew I was African American. And they already had their first impressions of African Americans, you know, prejudices or not. I mean, I can tell you when I was in the emergency room, I was interviewing patients. Sometimes they say, well, when is the real doctor going to be in? Or they thought I was an orderly. You know, back then if you watched the TV and news, typically what you saw on the news were African Americans. If they were females, they were hookers or prostitutes, and if they were males, they were uneducated or bank robbers on the TV shows. So that's sort of the stereotyping that people had those days, till Bill Cosby came on and said, hey, you know, there's an African American that can be a physician. So we're trying to manage impressions that people have. Now, these are my colleagues now, pretty modern. He's got his iPhone in while he's at work, wearing clogs, wearing scrubs. So these are some of the generational transformations that play a role in culture. So why is cultural linguistics important? And some of you probably have seen this, and the idea behind this slide is that we all have a different perspective on what we see. So here's a lady, you can see actually two visions. You can see an old woman, and you can see her chin here and her mouth here, but also if you just kind of cover up this part and you start from this side, you see a woman on the side. Here her eyes, here's her nose, and this is her ear. So again, just pointing out that people have different perceptions of things, and we have to take that into account when we take care of different people from different cultural backgrounds. Okay, well, the federal government's got involved in this, and they've developed these CLAS standards, which, as I said, St. Luke's Hospital System has adopted as part of their strategic plan. There are 14 standards promulgated by the USS Department of Health and Human Services, their Office of Minority Health, and they've actually been around since 2001. They're currently in the process of updating it. But they were basically to kind of help us be aware of individual cultural and linguistic needs of our patients, and to also talk about the elimination of racial and ethnic healthcare disparities, which actually improves the healthcare for everybody. What they've learned is that if they target specific disparities and they implement processes to eliminate those disparities, healthcare actually improves for everyone. So what is a disparity? Racial or ethnic disparities are differences in the quality of health care received by members of different racial or ethnic groups that are not explained by other factors. So what is the evidence that there are health care disparities? Well, there was a book published called Unequal Treatment, and it was actually about 2 inches thick, and it had over 400 articles about racial and ethnic disparities within our country. And in the category of ACS, African Americans less likely to receive standard reperfusion therapies. Those that are reperfused, the door-to-needle time is significantly longer for African Americans, Hispanics, and Asian patients. 60% of heart attack patients that are white versus 39% that are African American versus 35% other non-whites receive cath. Just getting an EKG in the emergency room is also delayed with minorities, and women are less likely to get the 2B, 3A clot-busting drugs. VA studies they looked at, African Americans were a third less likely to get cath, 44% less likely to get angioplasty, and 54% less likely to get CABG. And of course, the interesting thing about this is that since it was a VA study, there were no financial incentives involved in this. And just as a quick splattering of some others, when we looked at PEDS cases, California and New York, significant increase in the rate of ruptured appendix in minority patients. Stroke, African American patients were a third less likely, again, to get the clot busters. This was interesting to me because it's my own specialty. This study, in terms of treatment of pain, and it was repeated first in Los Angeles and then in Atlanta, that minorities were less likely to get pain medication for the same type of long bone fractures. And this was a pretty interesting study published in the New England Journal of Medicine by Schulman. And what they did is they paid actors and they gave them scripts for chest pain and said, you know, we want you to go in these doctors' offices and say you've got chest pain radiating down your arms, et cetera, et cetera. And it was interesting when they did the study, they found out that African American females with the same symptoms were less likely to get recommendations for catheterization. So, you know, you can call these biases a number of things. And as I said in this book, they chronicalized a lot of different things. Minorities less likely to receive needed services, including clinically necessary procedures, after controlling even for access. African Americans are more likely than whites to receive less desirable services, such as amputations. And so, you know, when you sort of look at it, when minorities want more services, they don't get them. Services that they don't want, like amputation. So you look at things like orchiectomies, you know, higher in African Americans than in minorities. When you look at amputation for diabetes, you know, limbs are salvaged more for the majority. So there are a lot of issues. I mean, socioeconomic status, obviously, a lot of things that play a role in healthcare disparities, but obviously there's some internal things that we as a specialty have to look at. You might remember Dr. Fiba talking about medical errors in the past, and number of people who died in U.S. hospitals due to potentially preventable in-hospital errors. And actually, when you look at those, this was initially 95 to 2005 and repeated in 2006, that communication was a leading cause of that. Patients don't understand we're not communicating very well and effectively with our patients, so they understand what they should and should not do. So the take-home point would be that if we are more culturally and linguistically competent, we would impact on some of these preventable deaths. We know our populations are growing, so if we have these disparities now, as we look at the projections for the growth of Hispanics and Asians and African Americans in our country, those disparities are going to increase, and that's going to cost our country a lot more. So it raises the question, is it important to treat everybody equally? How many would say that? Okay, well, actually, we don't want to treat everybody equally because they are different. And that's the whole concept, that we want to treat people, we talk about that, but we want to treat people appropriately. We want to respect their individual cultures. We want to treat them from a patient-centered standpoint, and you're going to hear a lot more about this term, patient-centered. I mean, it's a real buzzword now in terms of making sure, again, that we tailor our care and our approach to patients in a manner that they understand. So it's not about equality, but it's about equity in how we provide patient care. Why is that a problem for healthcare? Where, you know, again, changing demographics mean changing cultural norms. Changing cultural norms mean changing healthcare needs. And changing healthcare needs, if we don't address things in a patient-centered manner, will increase disparities, increase cost of healthcare, and increase the number of lives that are lost. It's a business problem as well. As we know, everything's global now, so we have to look at the health of our workforce. General Motors figured out that over $3,000 of every car they sell is just on healthcare costs. So we have to compete globally with people that are building cars in Japan, and that's a problem. Our workforce needs to be healthy and productive. We want to decrease healthcare costs and also decrease lawsuits. So, you know, healthcare is actually a little late in getting into this cultural linguistic competency thing. The business community started early. Some of you might remember the Chevy Nova, very popular car. They tried to take that car to Mexico and sell it because it was doing so well in the United States. Anybody who speaks Spanish? Okay, well, Nova in Spanish means no-go. So you can imagine taking a car and trying to sell it in a country where it says, I've got a car that doesn't work. It didn't work very well. The advertisement got milk a few years ago here in the United States. If you translate that specifically, it means I'm lactating in Spanish. So that didn't work out very well. In Africa, because of the multiple different dialects, they would typically put a picture of what's in a container on the outside of a container, because everybody could, you know, if it looked like a grain of wheat, then they knew that was wheat. So you can imagine what happened when the Gerber Company went and started bringing their contents to Africa. People thought, you mean there's ground up baby in there? So again, you know, all these missteps from a cultural standpoint. So we know cultural competence has to do with values, beliefs, attitudes, and behaviors. And then there's linguistic competence, and it's the knowledge and use of tools to address communication issues. And those are language tools, interpreters for people that are limited English proficient, people that have disabilities that are hard of hearing or visually impaired, and education levels and healthcare literacy. And this is huge. You know, when we send, Doug talked about discharge instructions, you know, when we look at healthcare information that we give our patients, what educational level do you think most of that information is written in? If you said, you know, you think it's high school, do you think it's college? What do you think? Well, actually, it's around the 11th grade level, okay? And do you want to know what the average literacy rate of our country is? There's a TV show about it. Are you smarter than a 5th grader? Okay? So that's a huge gap. You know, we're asking people to do things that they don't understand. So that's part of educating ourselves to communicate more effectively with our patients. All of these things together come together to promote effective healthcare communication in a cross-cultural situation. So what's a cross-cultural situation? Well, when you think about it, actually, every patient interaction is a cross-cultural situation. You know, even if you had twins in your office, depending on where one of them went to college versus another who maybe didn't, they will have different life perceptions, they will have different expectations. So we have to be aware that every situation is cross-cultural. So take a step back, think about our own biases and prejudices, and then try to relate the best way we can with our patients. Linguistic competency. So some examples of how those things especially impact patient safety. Take one daily until gone. Now, when it says take once daily until gone, you have to understand that that word once is actually once in Spanish. So we have had people that they've got prescription bottles, and you know, they kind of pick up the bottle, especially an older person. Let's say, you know, daughter brings grandmother in and gets her prescription, and grandmother gets the bottle, and she's at home alone, and she can pick out one word on a prescription. It says 11. You know, wasn't really explained very well, so she takes 11 tablets. Take 1 teaspoon 3 times a day until gone. Not 3 times each day, but 3 times a day. So they take it 3 times at 8 o'clock in the morning, 3 times at 10 o'clock in the morning, and they take it until the whole bottle is gone. Okay, just a slight misunderstanding of what's going on there. Do you have chest pain? Typically we ask that in the emergency room, but we know that sometimes it's not pain, it's a pressure or an ache. So you can imagine if you have somebody that's not a competent interpreter and they just say, well, do you have chest pain? The patient says no, and you move on to the next question. Well, somehow, and one of the things that you learn about using interpreters is that they're actually cultural brokers. I mean, you know if somebody, so when you have chest pain, they go, no, and then you kind of know to prompt, well, so is it an ache? Is it a pressure? And you use the synonyms. Your interpreters will help you pick up on those clues that you might not ordinarily pick up on. Diagnosis and treatment problems. Take these pills for your hypertension. The guy goes to his doctor's office, and the doctor says at the end, well, you know what, you have hypertension, and take these pills. And the patient walks out. And he goes home to his wife and he says, you know, I don't know what this has to do with lowering my blood pressure. You know, the doctor didn't explain the simple connection between hypertension and high blood pressure. And then the other error that comes in this is that the patient stops taking his blood pressure medicine after his prescription runs out. You know, when you think about it, the first time you get a prescription like that, historically, you've gotten a prescription growing up, you know, it's for a sore throat or for some acute pain episode, and you take it till it goes away and that's it. You don't sit down and specifically say, you have to take this for the rest of your life. And then they don't come back and they don't take the medicine and they end up with a stroke. This is pretty interesting. 1 in 7 U.S. adults unable to read this story. So again, talking about 32 million people in the USA that are illiterate. And then you take that and say, well, now, how about healthcare specific literacy? And you realize the big problem that we have here in the country in terms of effectively communicating with our patients. So limited English proficient patients have health literacy problems. They have difficulty understanding health information, physician instructions, navigating the healthcare system. We have signs for our OB ward in Spanish because we have more patients to go there, and that makes sense. You go to New York, and they have all sorts of different direction signs for people that don't speak English well. We've already talked about issues with reading prescriptions on label. So if these things aren't addressed in a culturally sensitive and competent way, and part of the cultural part of this is even understanding whether patients get it or not. You're not going to have, if you ask a patient, do you understand this? And shake your head, what are they more likely going to do? They're going to nod their head. No one wants to admit to being illiterate or stupid or not understanding their doctor. So you really have to take the time to tease that out and make sure they understand what you've told them. And one of the methods to do that is what we call teach back, because we actually ask the patient to tell us what they understood to do. So besides medication errors, missed appointments, non-compliance, adverse medical outcomes, and malpractices, we know communication plays a huge role in that. So communication leads to better patient satisfaction, better patient adherence. This is the term that's being used more and more rather than compliance. This is a non-compliant patient. Well, we have to put ourselves maybe in that patient's shoes. If that patient doesn't have a car and they have to take a bus to get to their doctor's appointment, or they have to make a decision between paying for an expensive antibiotic or taking care of their children. These are all the things that may go into what we perceive as non-compliance. But and the other thing I think they're implying with adherence is that it's not like, well, I'm a doctor, I told you what to do, and you're not complying. The whole interaction between the patient and the physician is supposed to be one of mutual respect and understanding. So adherence is a less pejorative sort of term, and there are other reasons why they may have different outcomes and reasons that they didn't adhere to what was the best care recommendations that you gave them. Tips on recognizing these issues: non-compliance with their medication, missed appointments, misdiagnostic testing, incomplete registration forms, chronic no-shows, unexpected responses when asked to read things back. And there's an exercise they recommend for internists is just to tell your patients to bring all their medications in a brown bag. And it's been amazing, the sort of feedback when you actually ask your patients and you find 2 or 3 prescriptions for Coumadin, well, this doctor gave me 1 milligram, this doctor gave me 2, and so I thought, when I left the hospital, I got this one, so I've been taking that one and the old one. I mean, all kinds of things were, because of multiple providers or whatever that people are doing that are a risk to their health. So the CLAS standards. As I said, there are 14 standards, and these are actually 1 through 7 are mandatory standards. They have to do with language access, and they were actually part of Title VI of the Civil Rights Act in 1964. So actually, technically, if you're not following these, you're in violation of federal law. Classes for healthcare organizations in their communities, state and federal policymakers are making policies around these standards. The medical community, actually New Jersey in 2005 was the first state to require at least 1 hour of cultural training in order to get recurrence license, and other states have come on board with requirements to do that. Obviously, pay for performance. If you have unequal outcomes, you may get less money. So you can think of a cultural scenario that would play a role. You have a patient that's Hispanic and they've come in with heart failure, and you have them seen by a not culturally competent dietitian who gives them sort of the usual American diet things in terms of not eating salty food, etc., rather than giving them a diet that is culturally appropriate for them, where you talk to them about beans, etc. So if they come back in with heart failure the second time, and this is what the government is saying now, well, we're not going to pay you for 30-day readmissions, well, maybe some of that is our fault because we really haven't provided culturally appropriate care in terms of educating that patient how to be more compliant or more adherent and healthy with their care. And of course, Joint Commission, NCQA, the AMA, AAMC, all of these organizations are also developing standards around cultural and linguistic competence. So here's an example of some of the issues we get into. 81-year-old Vietnamese female, Miss Nguyen, appears to be in bad health, complaining via her granddaughter as an interpreter of recurrent pain, likely the result of advanced cervical cancer. Now, she doesn't speak any English.
Dr. Rivera, good morning to you too, Lisa. Hello, Mrs. Lian. How are you feeling today? Good? Her stomach is so dirty, and she hardly eats much at all. Lisa, I need for you to ask your grandmother if she's experienced any discharge or bleeding. Bleeding? We take good care of her. We even let her hurt herself. Lisa, I know you take good care of her. We wouldn't let anything happen to her. But I really need for you to ask her if she's been bleeding. Small cut and didn't bleed much. Lisa, did you ask your grandmother if she cut herself or if she was bleeding? I asked her if she cut herself and was bleeding. Lisa, that's not what I mean. I need to know if she was bleeding, not if she cut herself. She's not bleeding. You can see there's no blood. Lisa, I don't mean that your grandmother might have cut herself, dear. I need to know if she's bleeding on the inside, from here. Well, if she's bleeding on the inside, how would we know? The blood would come out of her body. From where? From her body parts. I can ask grandmother about that. Lisa, please, I need you to be a really girl and ask her. It's very important. What was that? She said she's fine. I shouldn't worry about her. About the blood. We don't talk about things like that. I just can't. Lisa, is there someone else that could come in with your grandmother, another family member, a friend, a grown-up you could translate for? I think our upset neighbor could come tomorrow. The problem is that she refuses to eat. Her daughter, Lily, my friend, cooks everything for her, but she refuses to eat. She never should have come here. This country is too much for her. I need to know if she's experiencing any vaginal discharge or bleeding. Could you ask her for me? She's too old for that, doctor. I'm aware of her age. Please, I need for you to ask her. It's very important. I suspect Mrs. Lian might be suffering from cervical cancer.
Nếu mà tôi đau hông thì tôi phải đi cho tôi. Bà không chịu đi à? Không, tôi đau hông thì tôi phải đi. Nếu tôi đau hông thì tôi đi cho tôi.
She's not too fond of me. She thinks I spend too much time with Lily and don't leave her enough time to take care of her poor mother. And if you ask me, the old crone is perfectly capable of taking care of herself. Could you ask her if she's willing to go to a hospital? Don't bother, she won't. She is convinced that illness is a normal part of life and that she's earned the sickness she has. She won't go in for any special treatment. Well, could you ask her anyway? Bà ơi, bây giờ bà phải nói không nha. Bà ấy chịu đi nhà thương hay là không?
Nếu tôi đau thì tôi phải đi nhà thương. Tôi chịu đi nhà thương.
I told her she has to go, but she refuses. I told her she will die if she doesn't go, but she won't listen to me. She doesn't want any special treatment. What about for Lisa's sake? Ask her if she'll do it for Lisa's sake.
Con cháu bà mà chết thì ai con cháu bà ấy chịu đi nhà thương hay là không? Bà tôi nói không đi. Không.
Why would she let herself waste away like this? Oh, it's such a beautiful granddaughter. We miss you so much. Why has she refused treatment?
Because she's an old, stubborn woman.
Well, this is going well. Now what?
So what was the problem with the first vignette?
Using family as true player.
Okay.
And she's a kid.
So using family was a problem. Anything else?
She was like she was a child.
She's a child. Okay, I mean that's huge. I mean we talked about basic literacy, and now we talk about healthcare literacy. I mean, how appropriate is it to? I mean, and we know this happens, right? I mean, it's typically the kids that are bilingual and they come to your office or come to the emergency room, and you know. What if this had been a 14-year-old kid and you're going through the review of systems and you say, well, you know, ask your mom if she's had any STDs. I mean, would that be appropriate? So, and then you start talking about medical terminology with the 14-year-old who doesn't understand basic terminology, and then you're going to, again, add this layer of expected proficiency around healthcare terminology. So that's a huge issue, and not only is it culturally inappropriate, but again, just because they don't feel, you notice that she really didn't ask the question the first time because she just felt it was, and the doctor happened to pick up on that and said, well, ask her, bleeding from internally. The doctor could have just said, oh, okay, so there's no bleeding, end of story. I don't need to do a pelvic or anything else. I'm not worried about anything else because she's not having any bleeding. So again, you can see how it would change if you really had an interpreter. How about the second vignette? What went on there?
The interpreter was emotionally involved, so the interpreter didn't like the patient.
Huge. Yeah, the interpreter was biased. I mean, you can imagine, I mean, this country is too much for her. I don't need to ask her that question, doctor. She's not having sex. All of these, but she doesn't like me because she thinks, her daughter spends too much time with me. I mean, how accurate history are you going to get using a family member? And, you have issues of potential domestic violence. I mean, what if the husband's the interpreter? What sort of communication accuracy do you think you're going to get there? So it's actually recommended that for all of these patients you have an interpreter present. Now they may say we don't need one, but sometimes it's interesting to have one there anyway because they pick up, again, you don't know the healthcare literacy of that family interpreter, even if they, are they a college level graduate or not. So you really don't know how accurate the information is that you're giving without having an interpreter there.
But the basic process of having an interpreter is that you aren't supposed to be talking to the interpreter. You're supposed to be talking to the patient.
Right.
And you can pretty quickly tell if you're talking to the patient and the interpreter is saying what you're saying. You can look at the patient and tell that. And if that's not happening, then you don't have an interpreter, and you got it.
Yeah, I think that's really challenging.
I had 13-year-olds that did fine as an interpreter. They asked difficult questions. They asked indiscreet questions. They said what I said. And they made it clear to me at the start that they would say what I said.
Well, that's excellent. I mean, that's one of the things about using interpreters is that you need to not just sort of walk in a room with an interpreter, but there's certain ground rules you need to have. And so if you establish those ground rules saying, you know what, you ask the exact question the exact way I phrase it, because we all know we can phrase things a lot differently and get a different response. That's why an attending goes into a room and asks a patient a question, and it's the same question the resident, the medical student, and they get a different answer. It's because we asked it just slightly differently and we got a different answer. And all those things are germane to what happens when you go through an interpreter. So sometimes you can pick that up, and sometimes you might ask a question that has a sentence that has 4 words in it, and it's a 15-minute translation. So you realize there's a lot of other stuff going on in there that you don't know whether the person's injecting a bias. You know, do you have chest pain? No, I mean pain like it's, you know, like you're going to die. And the patient goes, well, no, I don't have pain like I'm going to die. And the interpreter goes, well, nope, she doesn't have chest pain. So, I mean, those are all the subtleties that, as I said, when you actually have a qualified interpreter, helps to be a cultural broker and eliminate some of those potential miscommunications. So, as I said, there are these standards that are federally mandated. Healthcare organizations must offer and provide language assistance services, including bilingual staff and interpreter services, at no cost to each patient with limited English proficiency at all points of contact in a timely manner during all hours of operation. So that's one of the things that we have to do as an institution. They have to also make sure that it's in their preferred language. So we use language identification cards. We post and maintain signs with regularly encountered languages. So for us, Spanish is our biggest one. Create uniform procedures for timely and effective telephone communication between staff and patients. So on the floors, we have some of those communication devices. Include statements about services available and the right to free language assistance services. So these are things, again, that sort of we were mandated by law to do. Healthcare organizations must ensure the competence of the language assistance provided to the limited English proficient patients. And we're fortunate, for the first time, there's a national standard, a national test that all interpreters have to take. And I think there are about 60 people that took the first test just last year, and one of those was a person from our institution and passed. And but we have our own internal test that we provide, that we administer to all of our interpreters to make sure that they are actually proficient and doing interpretations. Patient consumers may choose a family member after being informed of the free services available. So again, we want to document in the chart, because if there's a problem, we want to say, you know what, we offered an interpreter. But being patient-centered, if a patient says, no, I don't want to discuss this with anybody else, but you know, my best friend Mary, that's okay. We just need to document that in the chart. As I mentioned before, we'd like to use a trained interpreter, and minor children should never be used as interpreters. And number 7, healthcare organizations must make available easily understood patient-related materials, post signage in languages of the commonly encountered groups in that area. So written policies and procedures, minimum translation process, and again, just one of those little intricacies that changing something from English to Spanish isn't always the same thing if you change it from Spanish back to English. So we have what we call back translation to make sure that it's 100%. And some organizations use websites like Google, and we found inaccuracies, especially when it comes to translating medical information that's not accurate. So one of those things that we want to be careful about. This is sort of interesting. Anne's gone now, but jury awards $400,000 to a deaf patient for denial of interpreter services. And this talks about a deaf patient whose doctor was a rheumatologist, and the patient asked for an interpreter. And the doctor said, well, you know, I'm a solo practitioner. I can't afford, you know, $150 to $200 visit to have an interpreter there each time. And again, it's one of those, you know, typical sort of government unfunded mandates where they're not paying for it, but they're saying you're supposed to do it. And so the patient had been using a friend and also their 9-year-old daughter to try to help do some interpretation. I mentioned that there are a lot of organizations that are looking at these issues, and Joint Commission is one, and they came out with this monograph last year, Advancing Effective Communication, Cultural Competence, and Patient and Family-Centered Care. And they talk about how these things impact quality, safety, and equity, eliminating disparities. And we won't go into all of the things, but it talks about the importance for hospitals to identify the cultural and religious and spiritual needs of their patients. And you know, there are a lot of end-of-life issues that are culturally sensitive, and we talk about futility and how people expect us to do everything for everyone, and that's where a lot of our healthcare dollars are wasted. and a lot of these are cultural things. I've been privileged to be consulted on some of these cases and help to turn around expectations of people just languishing in the ICU for days at a time rather than passing on. Inform patients of their rights to have supported people. So and this was actually targeted toward gay patients, that if their significant other wanted to come in and they weren't necessarily married, that hospitals had to still allow them to see their significant other if they're in the ICU and sick. Identify preferred language, any communication needs, collecting race and ethnicity data. Introductions, this is something I thought was interesting because it really is important. I mean, you may not know all the cultural sensitivities of patients, but you certainly don't want to start your interaction with them on a downside. And some of this is generational, but you should ask your patient when you enter a room. Don't look at the name and say, "Oh, this is Betty. Hi, Betty. I'm Dr. Weaver." Well, what you should do is find out, what do you prefer to be called, Mr., Ms., whatever. And the same thing, tell them you can call me, because that is considered a respectful initial encounter. I mean, I can tell you again, some of this is generational. You may think, well, I'm being very casual and friendly by calling the patient by their first name, but I can tell you a lot of people in my culture, especially older people, feel it's disrespectful to do that without calling them by their Mrs. or names when you initially introduce yourself. Do you need help in understanding healthcare information? We need to ask that question. And again, we've talked about the teach-back method to make sure people understand what we've told them. Identify mobility needs, and there are a lot of state and federal laws around this. Again, sort of to Greg's comment about using the interpreter, the triadic method, and this is important. Again, you want to talk to the interpreter before you enter the room and say, it's sort of like a lot of times before I see a patient, the nurse will give me a kind of a background. Well, this person has no insurance, their daughter just died, something to kind of help you maybe connect and understand some of their cultural background before you see them. So having a pre-session, then you have the interview session, and then a debriefing. Do you think the patient really understood what I said? Was I effective in communicating? Did I ask the right questions? Do you think that I got it? So, as Greg was saying, the provider speaks directly to the patient. This triadic method here, and there's actually a whole list of all the different things that before you do the interview, during the interview, like speaking in short sentences. You don't want a long question to be translated because that can be difficult for the interpreter to change. So again, I would really emphasize that we want to use our interpreters as much as possible. So in summary, I would say that, first of all is to remember that everybody is multicultural, so we have to consider not only what their socioeconomic status is, but sort of generational status, what part of the country. All these things play a role. We want to generalize, don't stereotype. So, it sort of makes sense that if you see an African American patient that you might ask them about whether they have sickle cell or not, but you don't want to assume that they do or don't. So one of the ways that we do this is say that the difference between generalizing versus stereotyping is when you generalize, that's the beginning of the conversation. You ask patients things, as opposed to stereotyping, which is sort of the end. It's sort of like, well, I'm just going to assume you have this, or you like this. I made a classic mistake. I don't know how many of you know Dr. Delgado, who's a radiologist here, but I had asked him, I set up an opportunity for all the residents to have a cultural immersion, and we were going down to Manny's to have this part of this immersion process, and I asked him to come and speak. And so he came down there, and I thought, oh, this will be great. This will, all the residents will really relate to this. And he said, Mike, I'm from Puerto Rico. I don't typically eat tacos. So I had made an assumption, that Dr. Delgado spoke Spanish, you know, this was his part of his cultural heritage. And as we know, there are a lot of different dialects as well as preferences that fall under the Hispanic or Latino label. So again, one of the things we want to remember. And remember the platinum rule. What's the golden rule? Do unto others, do unto you. Right. So the platinum rule is to do unto others as they would do unto themselves. Okay? The idea is it's not what you think is best for the patient. That's not patient-centered. It's what the patient feels is best. And you have to, you know, you have to be a cultural broker in those situations. You know, I had a woman that had breast cancer in the emergency room that was of Asian descent, and in that culture, for some families, you know, the father decides whether his wife knows anything about their health care. And it was like, well, in my country, I'm responsible, I'm obligated to tell the patient what they have. That's the patient-doctor, that's our relationship here. But that's not the way things work for them. And it was quite a dilemma. Fortunately, they had a child. I shouldn't say a child because she was in college, but she helped to be a cultural broker for that situation and allowed me to go to educate the husband as to, I mean, I think part of it, again, culturally, when you tell somebody, or tell people of Asian descent who are especially first generation for that country that they have cancer, I mean, there's typically nothing you can do, and people give up hope and die, as opposed to realizing there are things that we can do if we catch it early enough that there are things that we can do. So I can kind of understand historically why they have said, no, we just assume mom not know because she'll go on happy until she dies. But again, those are some of those situations we have to be aware of. And then finally, if you don't know, ask. It's better to ask people things you're not familiar with their culture, because like I said, you can't know all the different things that people think about, and you don't want to inappropriately or unnecessarily offend someone. So that's it in a short nutshell. As I said, there's a lot of information that goes on, but you'll hear more both about culture and linguistic competence, and if you have any difficulty with any patients, feel free to give me a call. I'd be happy to help out. And that's it.